السلام عليكم، أهلا وسهلا فيكم. اليوم في عنا محاضرة بعنوان الوقاية الثانوية من النشبات الدماغية، تعديل عوامل الخطورة. رح يقدمها الدكتور يحيى الإمام. الدكتور يحيى الإمام، بس نبذة تعريفية عنه: اختصاصي في الأمراض العصبية والنشبات الدماغية، استشاري في النشبات الدماغية في مؤسسة حمد الطبية في الدوحة في القطر. حاصل على الزمالة الدولي في النشب الدماغي في الكلية الملكية في إدنبرا بريطانيا. حاصل على درجة الماجستير في طب الأعصاب السريرة في جامعة لندن. درجة الماجستير في النشبات الدماغية من جامعة الدانوب في النمسا. طبيب في وحدة النشبات الدماغية في مؤسسة حمد الطبية. بروفيسور مساعد في كلية الطب في جامعة قطر. أهلا وسهلا فيك دكتور يحيى، ممكن تتفضل تباشر في المحاضرة.
شكرا دكتور ابراهيم على الاستضافه الجميله هذه. ان شاء الله I'll begin my lecture is going to be in English, and if you can allow me just to share my screen.
Yes, doctor, you can start.
Okay, can you see my slides?
Yes.
All right. So today we're going to speak about secondary stroke prevention. We'll speak about risk factors modification. So these are my topics of interest, and I have to acknowledge the resources that I have gotten some of the information from these two resources here you see on the screen. So this is the outline of the presentation. We'll go first over the introduction, then we'll go over why it's important to prevent stroke recurrence. Then we'll give a quick overview of traditional risk factors approach versus a much more modern, integrated, futuristic, physiology-driven approach. And then we'll have a few slides on special considerations for the neurologist or the vascular physician. And then we'll end with a take-home message. So I'm just going to stop here and look at this picture here. It's a very powerful picture. It pictured three of the world leaders in 1945 meeting in Yalta in Europe. And this is post-World War II. The Allies have won the war, and they've decided what to do, how to do to divide the spoils. So all three of these patients, or all three of these leaders, died of stroke or stroke complications in the next 10 years. So stroke, we are basically facing a stroke epidemic. The number of stroke-related deaths are increasing at an alarming rate, and it is one of the leading causes of disability in the adult population. And it's the second leading cause of death worldwide, and the third leading cause of death and disability or disability-adjusted life years in the world. In the United States, on average, every 4 minutes somebody dies with a stroke. So it's very important, to prevent them. And if you prevent one of them, which is like hypertension, you can decrease about 50% of your stroke risk. So why is it important to prevent stroke? A stitch in time saves 9. درهم وقاية خير من قنطار علاج. So stroke survivors after the first index event, they will have a much more maybe severe, much more disabling, and even fatal strokes. And it will be much more costlier because it adds disability and takes away active people from the society to contribute to the society. And as time goes by, the risk of recurrence increases, and it can account for up to 30% prevalence if there's no successful secondary prevention. And if we implement effective and appropriate secondary prevention, we can reduce the burden of stroke by a quarter, which is very significant. These are the additional risk factors that people speak about. Hypertension is basically one of the most important risk factors for both hemorrhagic and ischemic strokes. Diabetes, inactivity, smoking, obesity. Some of them are, you cannot modify them. We call them non-modifiables, such as age. The older you get, the more strokes you have. If you have a prior stroke or TIA, you cannot modify that. Gets you at increased risk of a further stroke in the future. If you have family history, if you come from certain ethnicities, for example, Russian ethnicity have higher risk of stroke worldwide. Some people in Southeast Asia, they have premature risk factors and they have premature strokes. And some of them are modifiable, such as the ones I've mentioned before. Well, if you want to look at an integrated physiologically driven approach, then you have two pillars. On one side, you have the etiological classification of stroke. You need to find out what caused the stroke, and you treat the most likely underlying pathology. And then on the other hand, these are other physiological processes that are increasing risk of stroke, such as inflammation. And now we have a lot of biomarkers that are, in the pipeline, trying to figure out which people have much more inflammation and how we can prevent them. So inflammation, for example, people who have periodontal disease may have an increased risk of stroke. People who have rheumatological disease, if they have higher CRP, higher homocysteine. And obviously, this regulation of lipids and metabolism of glucose is also very important, as they feed into atherosclerosis and inflammation as well. Hypertension and arterial stiffness is very important. As I said, it's one of the most important risk factors. And you have to figure out what's going on with the body physiology. So we need to figure out the patient is hypertensive or not. And there's new ways of figuring that out. For example, the gold standard now is basically doing a 24-hour ambulatory blood pressure monitoring to diagnose, and not to go further and even characterize the patterns of blood pressure during the day. Do you have a nocturnal dip, or you're non-dipper, and so on and so forth. Lifestyle factors are very important, and as well as smoking cessation, which is of particular interest in our community, which we have a higher rates of smoking in our population. So early recurrence, as the risk of stroke is front-loaded. So the risk is very high in initial few days. You can get up to 10% of strokes in the first 2 weeks. And therefore, it is very important to treat. It's a medical emergency to treat strokes and TIAs. And there's a saying that stroke begets stroke. So the more stroke you have, the more stroke you get. So when you have early recurrence, it's very important to treat these patients in stroke units and rapid access TIA clinics. Stroke unit intervention is in itself an intervention. And this has been proven by multiple clinical trials that showed that keeping patients in specialized units where there's a multidisciplinary approach and people with expertise in stroke care makes a big difference as opposed to people who are admitted in any ward. And they have a number needed to treat similar to aspirin. So admitting a patient to a stroke unit is actually equivalent to giving a patient aspirin. So then during the stroke unit, you evaluate for the cause of the stroke. Could it be large atherosclerosis? Could it be small vessel disease or lacunar type stroke? Could it be cardioembolic? Could it be other causes that are well defined, such as dissection, polycythemia, hemolytic disease, and the like? Or cryptogenic, which is basically a fancy word that doctors use to say that we don't know what's the cause. So these figures usually vary between population and the other. In our region, in the Arab world, we have much more lacunar type and much more intracranial atherosclerosis, and we have less cardioembolic strokes as compared to, for example, Caucasians, who have much more cardioembolic and large artery atherosclerosis extracranially. And then cryptogenic is an interesting concept that people are trying to look into. And a subcategory of cryptogenic is what we call embolic stroke of unknown source, which are embolic-looking strokes without any smoking gun or causes that can be found. And some of them turn out to have underlying paroxysmal atrial fibrillation. So I'll discuss this later when we speak about atrial fibrillation. So for the early recurrence, obviously, we have our tools. We have antiplatelets or anticoagulation, and we need to decide, are we going to give the patient single antiplatelets or double antiplatelets? I think you're going to have a seminar or a webinar on antiplatelet therapy. I'm just going to touch very briefly on it. Anticoagulation, we have warfarin, we have DOACs, and we have statins. Statins are very important in substance. They have a role in stroke recurrence. And then we have surgery, either stenting or endarterectomy. Then we have to take care of other risk factors, hypertension, diabetes. I will go into them in details, lifestyle and diet. Antiplatelets, briefly, aspirin. It's a well-known ubiquitous drug that is found everywhere. It's cheap. And all patients with TIA and stroke should be given at least 160 of aspirin as a single loading dose. And if you are dysphagic, you can be given through the NGT or birectal suppositories. If you give the patient thrombolysis, you have to wait 24 hours before giving them aspirin. You do a CT scan. If there's no bleeding, then you can start your aspirin. And the American Heart Association guidelines say that any dose between 50 and 325 is acceptable, and it should be continued indefinitely. So in some people, they are allergic to aspirin or they cannot take aspirin, then clopidogrel or Plavix can be given as an alternative, or as a step up. If you already had a stroke on aspirin, in spite of everything else is controlled, then you can step up to clopidogrel, or you can give a combination of aspirin and extended release dipyridamole. However, this last combination is not well tolerated. A lot of people have a lot of headaches, and you cannot prescribe them to people who have, for example, active MI, active coronary heart disease, as it causes some vasospasm. All right. So when we give patients double, and when do we give patients single antiplatelets? So the role in stroke neurology is we like single antiplatelets. We don't like to give double antiplatelets. Somebody raise his hand. Yes. Did anybody raise his hand? Okay, I'll just continue, and we'll keep the questions at the end.
تمام دكتور يحيى. بالنسبة بدي أسأل سؤال بيعرفه اللي عم يحضروا، إنه أي واحد يسأل سؤال ممكن يكتب على الشات، وممكن إحنا إن شاء الله بنهاية المحاضرة تجاوب حضرتك على الأسئلة.
Okay, ممتاز. All right. So going back to the question about single versus double. So the role is single. However, there is some place to give patients double antiplatelets, and those are high-risk patients such as TIA or early minor stroke. And we have two large pivotal trials: the CHANCE, which is the Chinese trial, and the POINTS trial, which was done in North America. And they wanted to give patients double antiplatelets in the initial phase because there's a high risk of recurrence in the initial phase, without going into long-term double antiplatelets, because we know that long-term antiplatelets has no good benefit and may lead to bleeding complications. The other one is if you have symptomatic, more than 50% large vessel atherosclerotic stenosis, and this is from the SAMPRESS trial, and we give double antiplatelets for 90 days. As I said, long-term use for more than 3 months of double antiplatelets is not recommended because there's a cumulative risk of bleeding without much benefit. For the long-term prognosis, as I said, the recurrence is cumulative. At 1 year, we have 11% will have recurrence. At 5 years, almost a quarter, and at 10 years, almost 40%. What are the predictors? If you have prevalent vascular risk factors, if you are older, you have high blood pressure, you have diabetes or smoking, if you have a previous symptomatic vascular disease either in the same bed or other beds, such as a myocardial infarction or peripheral vascular disease, and if your other vascular disease is unstable. Obviously, if you have embolic source, there's also a source of recurrence, and you have to anticoagulate them. And sometimes cerebral microbleeds, where they can have what we call amyloid spills. You can have lots of recurrence because of minor bleeding happening in the brain. So let's speak about hypertension. So hypertension is important, still remains underdiagnosed in 11% of cases, what we call masked hypertension. So sometimes we need to do 24-hour ambulatory blood pressure monitoring to find this out. And usually we advise for gradual lowering of the blood pressure in all stroke patients. And the dictum is that in the initial phase, we allow for permissive hypertension because the brain is using this high blood pressure to drive in the blood supply to the brain to the ischemic area. However, we need to then lower it down gradually. And most of the time, the ideal time is not well described. However, usually after investigations, after more than 48 hours, usually we can bring down the blood pressure safely if it's not large vessel occlusion, for example. The optimal blood pressure will depend on comorbidities. For example, diabetics, LVH, or CKD can use ACE inhibitors. If you are a black race, you can use calcium channel blockers. And particularly, Prognosis has some benefit in stroke patients, irrespective of the blood pressure lowering properties. And this is what we find from the Progress trial, showed that Prognosis may be one of the most important drugs. But similarly, other ACE inhibitors and ARBs as a class effect may have similar activity on the prognosis as well. The target blood pressure should be lower than 130 millimeters, especially in patients with lacunar strokes. And if we can reduce it by 5 millimeter in systolic, then you reduce the risk of stroke by a fifth. If you reduce it by 10 millimeters, you can reduce actually the risk of further recurrent stroke by a third. Diabetes and glucose. So we know from the large pivotal trials, the UKPDS and the DCCT, that tight glycemic control is actually recommended for microvascular complications such as retinopathy, neuropathy, and nephropathy. However, we want to have high glucose is associated with inflammation, associated with other things. So we need to achieve HbA1c is less than 7%. But obviously, we need to individualize according to the age and according to the presence of hyperglycemia and other factors. If the patient has frequent hyperglycemia, then we can be a little bit lenient in his HbA1c and maybe aim for a target of 7 to 8. Choice of treatment should include with proven cardiovascular benefits. So people speak about metformin, speak about GLP inhibitors, which are important in reducing further strokes and MIs. And in patients who have diabetes, it's usually a multi-dimensional care. It's not just drugs, it's lifestyle counseling, nutritional advice, education, support, and medication. Screening for prediabetes is important. So every patient who comes in with a stroke should have an HbA1c done. And if you've diagnosed prediabetes, which is basically elevated HbA1c, not to the level of 7%, most people take it as more than 6%. And some people take it of 6.2% up to 7%, up to 6.5%, sorry. So this is a cause. These people can convert to diabetes. So it's worthwhile keeping an eye on them and in initiation of physical therapy and lifestyle advice as well. And there's also very weak evidence to suggest that pioglitazone in patients who have insulin resistance can be beneficial in stroke recurrence. However, the level of evidence is actually weak. Dyslipidemia. So we're very interested in lowering the low density lipoproteins, and this can be done by means of diet and lifestyle modifications in addition to statins. So we usually recommend moderate to high intensity. The Sparkle trial actually advocates high intensity statins, at least 80 milligrams of atorvastatin, and to be continued as it has a role in plaque stabilization and even plaque reduction. The target LDL is usually less than 2 millimoles and can go less sometimes in patients who have high Framingham scores to less than 1.8. And we aim also for triglyceride levels of less than 1.8 and a total cholesterol levels of less than 4. The HDL, we aim for a level of 1, and HDL is improved by diet and by exercise. If you don't achieve your LDL targets, then you can add cholesterol absorption inhibitors such as ezetimibe 10 milligram. When you have actually modest decreasing risk of recurrent stroke by 12% for every 1 millimole you reduce in your LDL cholesterol. Smoking and alcohol. So smoking, as I said, it's a big issue in our communities, especially shisha or hookah or hubble bubbly. And patients should stop smoking. Patient will try to rationalize their smoking, but the message should be that you need to stop smoking. So you need sometimes a combination of pharmacological therapy, nicotine replacement, bupiron, cysteine, or varenicline, and behavioral therapy should be considered. Alcohol consumption should be limited to less than 2 standard drinks. Alhamdulillah, in our community, we don't go for alcohol much. But if you're practicing and you have people who drink alcohol, they should limit their consumption to 2 standard drinks per day. So for men, it should be less than 40 drinks per week, and for women, it should be less than 9 per week. How about other lifestyle modifications? Exercise. Exercise is very important. So physical activity, they usually advise around 30 to 60, ideally around 40 PAs or patient physical activity of moderate to strenuous exercise 3 to 4 times per week. What I usually tell my patient is that after a stroke, start walking, start slow, and then build up your stamina. So start walking 10 minutes, and then you walk to 15 minutes, 20 minutes. You should, by the end of walking, you should be out of breath or sweating. So you need to exercise your heart. And if patients who have high risk, such as active cardiac disease, they need to be in a medically supervised exercise program. You need to reduce your body weight, and you have to have this is the ideal body weight, BMI, and you aim for a waist circumference of less than 80 centimeters in women and less than 94 in men. Diet, you aim for a healthy, balanced diet. The Mediterranean style diet, which is low in saturated fat, high in extra virgin oil and nut supplementation, low in sodium and high in fresh fruits, vegetables, and low in low-fat diaries. You aim to consume protein from plant sources and fish consumption, and to lessen the red meat consumption. And these are the recommended adequate daily sodium intakes that we usually recommend, and by no means should not exceed 2.3 grams per day at any age. So now let's just take some special considerations, some special scenarios. So how about cardioembolic stroke? I'll speak about atrial fibrillation, and I'll speak about patent foramen ovale. And then I'll speak about large artery atherosclerosis, and I'll compare endarterectomy versus stenting. So if related stroke, if related stroke, it's has higher morbidity and mortality. It has higher severity, and it usually has bigger strokes. In the Caucasian, it's 20 to 30%, but in our MENA region, Arabs, it's around 12%. And it's in Asians, in Southeast Asians, is much more lesser as well. It increases with age, and females apparently have more atrial fibrillation. The issues with atrial fibrillation is obviously the definition is a little bit fluid. It's at 8 minutes, 30 seconds, and people now are talking about the AF burden of AF. Sometimes you don't see AF on the ECG, and they can have what we call paroxysmal atrial fibrillation. And we know that from multiple clinical trials that the more you monitor, the more you detect AF. And if you strongly suspect AF, for example, in patients who have embolic stroke of unknown source, then you end up monitoring for longer periods. So the standard ECG has very low rates of detecting paroxysmal atrial fibrillation. If you go for a Holter monitoring for 48 hours, it's marginally increases the pickup rate. However, if you monitor for longer, you can pick up more AF, up to 20% more, especially in highly targeted populations such as embolic stroke of unknown source. So now the guidelines say that if you have embolic stroke of unknown source, you should monitor for a patient up to 3 weeks of monitoring. And then we speak about when to give DOACs and when to give warfarin. Now, DOACs have largely superseded warfarin. They are the go-to drug of choice in treating AF-related stroke. We have many drugs. We have dabigatran, we have apixaban, we have rivaroxaban, and edoxaban. Warfarin still has a role in valvular atrial fibrillation, as the DOACs are still not yet approved for valvular atrial fibrillation. Obviously, warfarin has some pros and some cons. The pros is that it's available everywhere. It's very, very cheap. It can be monitored. But the drawbacks, it's erratic way of, because it's enzyme related, and different people behave differently, and you need to monitor their INRs. And obviously, it has many interactions with other drugs and with food. So among the DOACs, probably dabigatran, the 150 dose, is superior to warfarin, and apixaban is also superior to warfarin. Rivaroxaban, in terms of efficacy, is non-inferior to warfarin. Then you have to choose when to give your patients DOACs and warfarin. Among the DOACs, the least DOAC that causes bleeding is apixaban. So multiple reports have shown that apixaban has less intracranial and less GI bleeding as compared to the other anticoagulants. When to start treatment with AF stroke? It's an issue that's still ongoing, and I usually follow this simple rule, which is published by Karl-Heinz Diener, who is a German neurologist who published extensively on timing of initiation of anticoagulation. And it states that on day 0 for a TIA, on day 3 for a minor stroke, on day 6 for a moderate stroke, and on day 12 or more in a large stroke. And sometimes you cannot even give them anticoagulation because of active bleeding, or there is, for example, cerebral amyloid angiopathy, and we cannot give the patient, bleeding, anticoagulation because of a high risk of bleeding. Then you may need to occlude the left atrial appendage, and by doing so, you can exclude up to 80-85% of clots there. PFO is the patent foramen ovale. It's a right to left shunt. It's usually very common in normal population, up to 10 to 25%, and it's much more commoner in patients in the stroke population. But how much of it is it causing stroke? So you have to recognize that the high-risk PFO, and I'm going to explain what is high-risk PFO in a second, that if we close them, we can reduce secondary events from closure. And we have 3 trials that have converted to just aspirin, and it is efficacious. And this is what we mean about high-risk PFO. The PFO with an atrial septal aneurysm, or hypermobility, or a very large PFO, more than 2 millimeters on TTE. And this is one of the devices that you use to occlude the PFO. It's called the Amplatzer, and it provides a moderate benefit, especially if the patient is under the age of 60, and if it's a cryptogenic non-lacunar stroke. However, keep in mind that PFOs in general have low risk of disabling strokes, regardless of the closure status. And because it's sometimes difficult with certainty to decide if it's causing the stroke or not, so sometimes we can use something called the ROP score. So the ROP score stands for the risk of paradoxical embolization score, and it assigns a score and gives you an idea of how much the PFO may be contributing to the stroke the patient has. And we know from Navigate ESUS and Respect ESUS trials that for patients who opt not to have their PFO closures, that antiplatelets are the treatment of choice rather than anticoagulation. And keep in mind that even after closure, you need to keep the patients on double antiplatelets for a month, and maybe another single antiplatelets for another 5 months. So you need to at least to give them antiplatelets for 6 months. Carotid disease, basically narrowing due to atherosclerosis, is the most common, and the bifurcation of the carotid artery. It constitutes around 20% of all of the adult population of all strokes. And if you have a TIA or stroke in the same territory of that carotid disease, it's termed symptomatic, and it's moderate, meaning 50 to 69, you can interfere, and if it's severe, 70 to 99%, you need also to interfere. Now the issues is when you have the less severe, the moderate ones, when to interfere and not when to interfere. And basically, you need to have a good surgeon with very low mortality and morbidity. And the stroke itself should not be like a retinal stroke, like an amorous fugax, and it should not be. And females usually do worse than males. So you can operate on these patients provided these conditions are met. And asymptomatic, which is contralateral to the stroke or just found incidentally, which is also very common. And we know that people may have stroke within 5 to 10 years. And there's now evidence that maybe we need to also to do something about them. And evidence is still in the pipeline. So what you do, you either do endarterectomy or stenting. And this is the graphical presentation of how we do endarterectomy and how we do stenting. So patients who have more than 50% stenosis, no total occlusion. If it's 100%, you don't do anything. And there should be no severe disability due to the infarct. The other control you can do either is do medication therapy, usually double antiplatelets, high dose statin, and you control the traditional risk factors. So the robust benefit is actually for the severe stenosis. The moderate benefit is, as I said, for the 50 to 69, and there's no benefit in amaurosis fugax in women. So when do you do endarterectomy and when do you do stenting? So endarterectomy, there's high upfront risk of complications because of the surgery and what is really complications of the surgery, and there's high risk of MIs, whereas there is less upfront risk of MI, but there's a high risk of perioperative stroke. There's less risk of recurrence. However, stenting, there's a high risk of recurrence and higher risk of instant occlusion. It's better for older patients because they have very much altered physiology. They have very tortuous or very heavily calcified arteries, and stenting is better for younger patients. And if patient has multiple comorbidities, then maybe also stenting may be the way to go. Either way, either if you do endarterectomy or stenting, they have a similar 4-year ipsilateral stroke rates as seen by the CREST trial. Now, the take-home messages. Recurrent stroke can be more severe and more disabling and can occur up to 30% of strokes. Implementing risk factor modification is important, such as lifestyle changes, diet, exercise, and weight reduction, in addition to pharmacotherapy. If you do all of this recipe, you can prevent up to 80% of recurrent strokes. AF-related stroke need to be diagnosed and treated as a high morbidity and mortality, and we have to look for and detect paroxysmal atrial fibrillation because it's also can go unnoticed. If co-closure in selected patients is very beneficial, and symptomatic rotated stenosis can be treated with either endarterectomy or stenting. And we know that there's robust evidence for severe stenosis and less robust evidence for moderate stenosis. I'll stop here. Thank you so much, and I'll be happy to answer any of your questions.
Thank you very much, Dr. Yahya, for your interesting and useful lecture. Dear colleagues, if you have any question, you can write on the chat or question and answer field. Dr. Yahya will answer for you.
Yes, I want to thank Dr. Yahya for coming over and providing a very good, excellent overview about risk factors.
Maher, how are you doing? Good to see you again.
MashaAllah, Shabab, MashaAllah. The same I left you, huh?
Yeah, only getting grayer.
We have one question in the question and answer.
Is that?
Yes, Dr. Yahya, the first question is the dose of the statin 80 milligram or 40 milligram.
Yes. So the role is for moderate to severe to high intensity statin. So if you go by the Sparkle trial actually advocated 80 milligrams of atorvastatin or 20 milligrams of rovastatin. And we know that statins have a big role, especially in atherosclerosis. They have beyond their lipid lowering activity, they have an anti-inflammatory role as well, and they can keep down the inflammation. And multiple clinical trials have shown that they can stabilize plaques, and they can even reduce the plaque surface and volume on multiple atherosclerosis. So usually, if it's a lacunar, I usually start with 40. And if it's a large vessel occlusion, I go for 80. That's how I usually treat my patients. I think that's the way we practice over here.
Thank you. Another question is the frequent strokes may lead to dementia.
So vascular dementia or vascular cognitive impairment is a big topic. It's a whole lecture on its own, and we know that strokes can lead to dementia or vascular cognitive impairment through different mechanisms, either from white matter changes that are building up due to your risk factors, and you can also have them if you have a strategically located strokes. For example, people who have, for example, thalamic strokes, they can have profound memory loss, or any strokes in this PAP circle, like in the temporal lobe, or in sometimes in some of the basal ganglia, they can have profound memory loss. Or they can have like a traditional stepwise approach when you have strokes after strokes, and you get cognitive impairment. So the short answer is yes, there's a big part of strokes that can lead to dementia, and vascular dementia is a big topic. However, I do believe that dementia is a combination of processes. So you don't find that pure Alzheimer or pure vascular. I think they are a mixture of both. And if you look at the risk factors for both, there's a lot of them that are shared between the two of them. So the short answer is yes, stroke can lead to dementia.
تمام.
Dr. Maher or Dr. Ibrahim?
Dr. Yahya, another question. If a patient have a stroke, and in the ultrasound we found about 60% stenosis in carotid artery, when we treatment endovascular or surgery for carotid artery?
So that's a very good question. So the you need to have more information about the patients. So how much is a stroke? How bad is a stroke? How disabling is a stroke? And what is the other risk factors of the patient? How old is he? Usually we advocate to have the endarterectomy within 2 weeks of the stroke, but obviously the earlier the better, and some people even say within a week. Obviously, if you wait, the benefit from endarterectomy goes down, and then by 6 months there's hardly any benefit because the risk of recurrence has gone. Now, a lot of the trials that I've mentioned that advocated endarterectomy are a little bit old, but we have now we have double antiplatelets. We have maybe even ticagrelor, which is a new antiplatelet, which is very efficacious. We have high dose statins. So these are maybe there's a debate in the strokes community whether medical therapy can be of help even on those sorts of patients. So if above 50, between 50 and 69%, that's a little bit of there's a modest benefit. If the patient is female, I'd rather not go for it because they have higher morbidity. And if it's just the stroke is just amaurogus fugax, I'll not go for it. But if it's a non-disabling stroke, 60%, you can go for it if it's symptomatic.
Dr. Ahmed, may I ask a question?
Yes. Another question. Do we increase the dose of statin until the tolerance is reached?
Obviously, our patients are a lot more pliable with statins. I don't know if Dr. Maher has much more experience with the Caucasians because they have a lot of misinformation and a lot of bias against statins. And I usually spend hours and hours, trying to convince my patients to be on a statin. So statins can cause a little bit of, myalgia. Rarely they can cause like frank myositis or liver disease. Usually we go by the LDL levels, right? We need to go to the target LDL levels, and we reach the target, no need to escalate further. So if you are on your target level, you can just keep on that. If you have very low LDL, there's a counter argument that very low levels of LDL can actually predispose to bleeding. This is a theoretical concern that has not been proven in clinical trials, but you may need to put on a brake if the level of LDL goes too low. And there is very little evidence suggests that very high doses of statin can lead to a little bit of brain shrinkage, because guess what? Your brain is made of lipids. And if you're using lipid reduction excessively, you may have a little bit of cognitive impairment. So the bottom line is you try to get your target, not too low and not too high.
Another question. If there is a mechanical valve and stroke, what is the approach?
So mechanical valves, is it with atrial fibrillation or without atrial fibrillation? So mechanical valve, the patient is already on anticoagulation, and you need to figure out if the patient is actually on anticoagulation and if he's meeting his INR targets. So a lot of our patients, they can have good INRs, but the time they spend in the therapeutic window is low. So you need to figure out if they're compliant and they're sticking to the therapeutic window or not. Sometimes you may need even to increase the target of your INR by 0.5. So usually for mechanical valves, the patient has a stroke, we can wait a few days until the patient's obviously depending on what type of valve he has. For example, aortic valve, it's a very high flow. You can wait a little bit, you can wait a few days, while mitral valve is much more sticky. It's a very sticky situation when you have a mitral replacement or aortic valve replacement and you have a stroke. But we usually wait for a few days. Sometimes we stop the anticoagulation. We start with parenteral anticoagulation that you can stop it very quickly, like IV heparin. We usually modify the dose and the PTT, and then take it and keep a close eye to look for hemorrhagic transformation. Once the initial period is passed, then we can reintroduce the warfarin and we can titrate the INR to the levels that are safe and that are efficacious.
Another question, are there risks for long-term use of multiple antiplatelets?
Yeah, so multiple, the stroke trial is, clinical trial has shown that if for the brain, so our colleagues in cardiology, they like antiplatelets. They give double, triple, quadruple, they like antiplatelets. For us in the brain, we know from multiple clinical trials that it's a cumulative effect. If you use double antiplatelets, there is a higher risk or cumulative risk of bleeding. So we only recommend single antiplatelets unless there is a indication. We go for double antiplatelets for a short period of time. So, for example, if you have a TIA or you have a minor stroke, you can give them double antiplatelets for 3 weeks. And if it's a large vessel atherosclerosis, you give them for 90 days. And that's how we usually advise people to use them.
If there is a recurrent stroke and the patient's on aspirin, is it indication to add dogrel or replace it?
Yeah, so recurrent antiplatelets on aspirin is an issue. First of all, before we try to replace, we have to look at all the risk factors catered for. Is he at target blood pressure? Is he at target LDL? Is he at target HbA1c? Did he stop smoking? Okay, is he taking the aspirin regularly? Is he compliant? All right, if everything is satisfied and the patient is quite well controlled, and in spite of that, he has a lacunar stroke, for example, then the advice from the American Heart Association is to replace, to give them clopidogrel. Some people, they have aspirin resistance, so they may benefit from a switch to clopidogrel. So we don't usually advise double antiplatelets. So always single antiplatelets, one over the other.
MashaAllah, Dr. Yahya, wonderful. One thing Dr. Yahya didn't mention, he did an extensive studies in risk factors in stroke in Qatar, and I'm sure he's still doing it. One thing I want to tell you about the map where we are, we already started having stroke prevention clinic in northern Syria, run by Dr. Ahmed and Dr. Ibrahim, mashallah, and we have a 5 residents now there. They are joining the clinics. That's in northern Syria. We already, Dr. Saima, already in the process of establishing stroke clinic in Peshawar. We are working on establishing tele-stroke clinic in Somalia. So, so definitely we need your help establishing a stroke clinic in Khartoum.
Absolutely, my pleasure. My pleasure. My pleasure.
The final question, can aphasia improve after a long period of time after repeated strokes?
Okay, so this is actually not part of the lecture, but it's a very common question that people ask about aphasia. So the traditional way of telling, breaking the bad news or breaking recovery for patient is that everything is usually individualized. And from data, we know that the amount of recovery is very fast in the first 3 months, but can lag up to 6 months, and even some people up to a year. After 9 months, 1 year, if there's no significant improvement, obviously most of the improvement should have happened in that period. After 9 months, 1 year, it's going to be very, very slow, if any, improvement in aphasia. It's going to be permanent. There's a lot of research going on now to figure out if there's any ways that can improve aphasia, either by doing some interventions, giving some drugs or antidepressants. But so far, there is no solid guideline-driven answer to that question yet. So aphasia is still a process, a self-healing process that the brain has to go into, and you just allow the brain to reboot itself and to function. Obviously, if you have recurrent strokes, then the amount of cerebral reserve is decreased, and you end up getting, worse recovery every time. So that's why it's very important to prevent recurrent stroke.
Thank you very much, Dr. Yahya. Thank you for this lecture. Thank you to all.
And we hope to have other lectures from you in the future.
Inshallah, God helping, inshallah.
Thank you.
Thank you so much. Okay, take care. Bye-bye.
Bye-bye.
Bye-bye.